So now we'll go over the admission of a patient and all of our surgical paperwork. So when an animal comes in to be admitted for surgery, our receptionist at the front of the desk will have the client's file, and then they will go over and verify with the owner that they have the correct dog, the sex, the species, and any pertinent major medical history. And then the owner will go through our estimate that is pre-made and verify everything. So in this case, this dog is going to be spayed, and also we're going to remove her rear dew claws. And the owner will go down through everything, agree or disagree, like to our microchip implant, they'll okay that or not. And then as long as the owner is okay with everything on board for the surgery, they will go ahead and give us consent and sign the paper saying that that dog is getting that specific surgery. Once the owner has signed the estimate saying that that dog is the correct dog and is getting that correct procedure, our kennel manager will come up to retrieve the dog to bring it back, and at that time we'll re-verify the dog's name and that it is getting that specific procedure, and we'll put a neck tag on the dog, thereby hopefully identifying it for good at the hospital with the dog's name and its ID number and the procedure it's getting done. And then on its cage here also it will have its name, its species or its breed, and what procedure it is getting done. Then once the dog comes back to us, the surgery team, we will first go over the estimate and verify everything that's on the estimate is what we have in our computer and our records that will be happening with the dog, and then we'll proceed to get all our paperwork labeled. So we have our anesthesia record form that will label with the dog's name. We have our controlled drug sheet with the patient's name, and then we have our regular drug request that we'll do pain meds to send home with. We use electronic medical records, EMRs, here at our hospital, so after we have the paperwork all labeled, we can go through this patient's medical records and make sure that it doesn't have any major issues we should know about, any adverse reactions to medication. We do have alerts that if there were something really wrong with the patient, reacts strongly to dextromethorphan, or is aggressive, anything we should know, it would pop up as soon as you click on the patient. And once we know for sure that everything is okay, we are okay to proceed, we would weigh our patient and figure out the drugs that we would need. So we do have, each doctor has its own anesthesia protocol depending on the procedure that's being done, and then we can further tailor that to the individual dog. So with this patient, we know that it is a 6-month-old Rottweiler, and there are some notes in the computer in her past record that she was a little difficult doing some vaccines. So for her, even though she's getting spayed, and we typically would use Hydro Index, we'll probably use Torpdex for her just to give her a little more sedation for the induction drug, and then switch to hydromorphone as her post-op pain med. So we have our drug sheet all filled out. This surgery is actually happening in a couple days, so I don't want to calculate her drugs until we weigh her, but this would be the drugs we'd be using. And then for her lab work, we always run a Chem 10 and a pro site here, so we would request that through the computer. So Chem 10 and a pro site. If we had a patient that was geriatric, we knew had some more serious issues, we would choose a Chem 17 and maybe even add in electrolytes as well. But for healthy routine procedures, we use Chem 10 and a pro site. And then we would send that to the lab. We create that request, we send the blood to the lab, And then once the blood work is run, we can see it in the computer, and they also print the paperwork off, so we have a hard copy of their blood work results as well. So once we have the animals' lab results back and verify that they are healthy for anesthesia, our doctor will do an exam, and as long as that checks out, we are able to submit our drug request over. And then we have our anesthesia record form. We'll put the amount of drugs and then initial and sign off the time once we give those drugs. We also keep track of their catheter, tube size used, and obviously what time we started anesthesia and how long they were under. On the back of this sheet is our anesthesia monitoring. So we try to do it every 5 minutes. We have the time, what type of gas they're using, SpO2, its heart rate, blood pressure, capillary refill time, respiratory rate, our bagging our patient, and then the fluids that she's on, and also our temperature. So occasionally we'll have owners that want to speak to a surgery technician before their animal goes under anesthesia. So if that were the case with this particular dog, this Rottweiler that's having her spay, we would go up and go through the estimate with the owner and explain everything that's going on. So Mrs. Reck, when your dog comes in, we'll take her back. We will draw some pre-anesthetic blood work to run and make sure that all our vital organs are functioning correctly, and she's got an adequate amount of platelets and red blood cells to go under anesthesia. And then our doctor will perform a complete physical, make sure heart sounds good, make sure lungs, everything sounds clear, so she'll be again okay for anesthesia. And when it's her turn, we will give her a pre-med, which will help her with some sedation so it's not so scary, and also give her a boost of pain control. When that starts to kick in, we'll take her back, we will shave her leg, front leg, put a catheter in so we can keep fluids going during anesthesia and also have an access to a vein if there was any emergency. We will then give her her induction drug, put a tube, intubate her, put a tube in her throat so we can then control the anesthetic gas and the oxygen. And once she's fully under anesthesia, we'll then prep her for surgery, so she'll get her belly shaved and cleaned. She'll go in, the doctor will make an incision, she removes her uterus and her ovaries, and then we'll stitch her back up. Our doctor, Dr. Hopper, uses absorbable suture, so she won't have to have any stitches removed. We just want to keep her quiet after surgery, and we'll go home all the go home instructions upon discharge. But she'll spend the night with us just to monitor her for any bleeding or any issues, and that way she can also stay on some more injectable pain meds until it's time to go home tomorrow morning. Now we have an example of our discharge instructions that we send home with all of our surgeries. So this is not the exact patient with the other paperwork. This is an example of a spay that was done last week. So it does describe what procedure was done. And then for our routine spays, they're okay to eat their regular diet. Here is where we would either have them do smaller meals or feed a special diet. But for our spay, she can have her normal food, and we want her to be quiet and leash walks for at least 14 days. Even to go outside to go to the bathroom, exercise, all on a leash, so it's not too much. We want to prevent her from doing excessive jumping in the house, up and off the bed, things like that, keep her down. And then she's going to go home with some Rimadyl for pain, and she's going to get that twice a day, and you can start that tonight when you take her home. Her sutures are absorbable, so they do not need to be removed, and she doesn't need a recheck unless anything changes. So what we want to make sure that you watch for is excessive swelling around the surgery site, any redness, any discharge, if it feels really warm to the touch, if she's acting off, acting punky, not wanting to eat, she feels like she has a fever. Those are all things to give us a call for. We also don't want her licking or scratching, particularly licking. So if you see that she's really chewing, licking at her incision, we will dispense an e-collar, an Elizabethan collar, for you to put on her just to make sure that she doesn't traumatize that incision site. So now we'll demonstrate how to restrain a cat and a dog for the different blood draws. So with a cat, for a jugular blood draw, you want to stretch their neck. Ideally they'd be in the sitting position and hold their head. Also, sometimes with certain cats, you can also, with one hand, hold their face, and with the other hand, stretch their legs out if they don't want to stand up for you. For a cephalic blood draw, you want to put your hand behind their elbow and use your thumb to roll and hold off the vein. And then in cats, with their medial saphenous vein, you're going to place them in lateral recumbency. And sometimes you need two people for this, one in the front and one in the back. The blood drawer would extend their hind leg, and you would put pressure at the top and hold down. Alright, and now restraining the dog for blood draw. For jugular, ideally they sit, it's the easiest. And you just want to hold their head up. Sometimes for a larger dog also, you can use your legs as a brace and keep them up. For a cephalic blood draw, put your hand behind their elbow and use your thumb to roll and occlude the vein. And then in dogs for their lateral saphenous, you can hold off right above the vein. Alright, so now we're going to get our kitty out of its cage. So I like to use here for any cat a blanket or a towel, just because you're not sure how they're going to react. And then fully supporting them. As you pull them out. And now with them in the towel, you could even do your pre-med injections or anything you needed to do. Or exam. And then to put them back, same thing, you can use a towel. If he had already had drugs or had pre-med. So for this patient, he's waking up from anesthesia. If we wanted to get him out of his cage and then to put him back, he's small enough, we can keep him in the towel and use the towel as a sling. So he's fully supported, his head and his body. And then gently put him back. And we like to keep their head at the front of the cage when they're recovering from anesthesia so we can keep an eye on them and make sure everything's okay. Okay, so now we're going to put a muzzle on this dog. So we'll have, the best way is to have somebody holding and kind of setting his head if possible. And then you want to come from behind and start at the top, and then you can secure it behind their ears. Good job, Addie. Alright, let mommy watch it. Alright, so now we're going to put an Elizabethan collar on this kitty. So to start with, I sort of measured or just eyeballed where his head would be. So we put that together, and then I've just got some rolled cotton, rolled gauze. If this were a patient that needed this after surgery, we usually do it right as they're waking up, so it's easier to put on, and they can't get to any of their areas where the surgery happened. For an awake cat, we'll just bend these back so it doesn't get his eyes, and then tie our gauze. You want about 1 or 2 fingers to be able to get in. You want it tight enough they can't get it off, but not too tight. Alright, so we're going to do a pre-surgical exam on this kitty. So to start with, he's purring, he's bright and alert. We'll check his mucous membranes. They're pink and nice and moist. His eyes are clear. And now we'll do a heart rate. So I have my clock up on the wall for our second hand. 40 beats in that 15 seconds, so times that by 4, and his heart rate is 160, which is normal. Now we can do check his lungs and make sure they're all clear and get a respiration right. So I got around 20, times 4 would be 80. He is purring, so it's a little more difficult to hear, but that would still be in the normal range. And lastly, we'll take his temperature. So 100.8, which is normal. So given that this cat's TPR values are in all the normal range, he's bright and alert, he would be a good candidate for surgery. Given the fact though that he is obese, he'd probably be a grade 2, a class 2 instead of a class 1, just for that reason, as long as his blood work checks out. So I'm going to perform a pre-surgical exam on this dog. So what we do know about him is that he can be a little bit difficult here, so he has had some trazodone, so he's a little bit more sedate, but that is only due to the trazodone. Otherwise, he does have a bald spot that he's had for his whole life, but otherwise he seems fine, healthy, he's in good body condition. So we're going to start by listening to his heart and take a heart rate and then a respiration. So I have my timer set for 15 seconds. Times 4 is 120. He's very nervous. And we can listen to his lungs and take a respiration rate. that would make a respiration rate 60. So we're going to finish with the temperature. So that's normal. And then we'll check his eyes are nice and clear, and his mucous membranes are pink and nice and moist. So overall, his respirations are normal, his chest is clear, his heart sounds good, there's no heart murmurs. He has a normal temperature, he's a normal body condition. So the only thing that he's, other than his trazodone, he's healthy otherwise. So with him, we won't need as much of a pre-med since he is already a little bit sedate. And he would be a young, he's 2 years old, his blood work checks out. He would be a score of 1 for ASA grade. So we're going to draw blood from this cat's jugular vein.
Oh, it's okay. Beautiful.
And you can stop it. Alright, so now we're going to draw from this cat's cephalic vein.
Beautiful.
Perfect. One more. So we're going to draw blood from the medial saphenous on this kitty. So I'll draw blood from this dog's jugular vein now. I'm just going to wet with some alcohol.
Cutting things out.
Good. So now we're going to draw blood on the cephalic vein of this dog. Okay.
Up you go.
Okay, so we're going to draw blood from the lateral saphenous.
Yeah. There's someone there I can text. Yeah, that's fine.
So aside from a physical by a veterinarian, ideally the minimum requirements for surgery would also include a PCV with total solids, a blood glucose, a BUN, and an ALT value. Here at our clinic, we require a current heartworm test as well as a Chem 10, so that also has a creatinine value, alk-phos, and a total prostate. If we were to come across an animal that, say, is having a mass removal we know is a cancerous mass, we would do chest radiographs and make sure that nothing had netted before that. Any animals that have heart issues, we require ECG. We also have an ECG monitor we use during surgery. And if there was any question about the heart, we would do chest radiographs ahead of time. Animals that we know are geriatric or have other issues, we also would do more complete blood counts with a Chem 17 and lights if need be. Otherwise, send out a full panel blood work prior to the surgery to know everything's okay ahead of time. So for putting our controlled substance, which is Torb, in our Torb log, we have our controlled drugs sheet that has the client's last name and our ID number for the clinic, the patient's name, and the drug, the amount, and the quantity, or the bottle number, I'm sorry. So we'll start with our log. Again, verify that it is the log for Torb. And go, we have our date. And then client's last name. And the pet's name. And then the client's ID number. The bottle number is 19-12. Our reason was for sedation. And the amount was 0.5. And now we want to subtract, so the amount on hand is 25.29, and then initial. So we're going to go over the parts of our anesthesia machine. So to start with, we have our oxygen hookup, which is the green tube, and we have our scavenger system. We have 2 sets of these in our surgery suite, and then we have one in our surgery prep area, our dental area, and our treatment area, as well as our ultrasound area and x-ray area. So we can have an anesthesia machine running in each of those. So then to start with, we have our oxygen flow meter. And when oxygen's on, you can turn the gauge and read the liters of oxygen. We have our oxygen flush valve. So the flow meter, like I said, allows you to know how many liters of oxygen you're delivering at a time. The oxygen flush valve allows you to bypass the anesthetic gas and give a breath of just pure oxygen. This is a semi-closed rebreathing system. So we have our expiratory tubing and our inspiratory tubing, as well as our unidirectional valves for each. And we have our pop-off valve up here. So this allows you to totally shut down the scavenger system and do a leak check. You always want to make sure that this is open before hooking a patient up, or the pressure could become too great and actually burst their lungs. We have our pressure gauge, our manometer, and our CO2 absorber. So this absorbs all the CO2 and condensation, things like that. So that way when the patient rebreathes, they're going to get oxygen and anesthetic gas and no CO2. We have our anesthetic gas vaporizer. So this particular one is isoflurane. So on our machine, the anesthetic vaporizer allows you to control the amount of anesthetic gas that is being delivered to the patient. So it's currently off, and we can go anywhere once you turn it on, up to 5. Typically for a surgery, we like to keep it between 1.5 and 2.5, depending on the patient's needs. Depending on the pre-med, also will indicate and dictate what level of gas we need. And then we have the CO2. The CO2 canister, and what this does is as the patient expels a breath, it goes through and the pellets absorb the carbon dioxide as well as excess moisture, and then the air is then passed through the inspiratory unidirectory valve and mixed with the oxygen and gas and goes back for the patient to breathe. So we also can use an anesthesia mask if needed. We use this for knocking down rabbits. We do a lot of rabbit spays and neuters here, but also if you're trying to just give oxygen to a patient, you can use the mask. Another option is an induction chamber, an induction box, and we use this here for fractious cats and sometimes for some small exotic pets if we need to get them knocked out quickly, either for euthanasia or for an emergency. And with this, we have the tubes, we take the Y connector out and we have the tubes connected here and then back to our anesthesia machine. And with both the mask and the chamber, you typically do need to turn your anesthesia up and your oxygen flow higher to account for the fact that you're going into a bigger space. So we have a scavenger system for each anesthesia machine hookup, and that scavenges the excess anesthetic gas out so we're not breathing it in as we're doing surgery. And then for our hospital, we have large oxygen tanks, and they're labeled depending on which zone of the hospital they're hooked up for. So we have one for one half of the hospital and another for the other, and we always have at least 2 full backup tanks. And with these, they're hooked up here, and then that goes through the green tubing to all the different areas of the hospital so that you're able to hook the anesthesia machine up to oxygen at each section. Okay, so now we're going to do a leak test on our anesthesia machine. So I have our breathing circuit hooked up and I've attached a reservoir bag. I'm going to close the pop-off valve. And turn our oxygen on to about 0.2. I'm going to close off the end of our breathing circuit and flush with oxygen until our reservoir bag is full and you can't see any of the folds. And now make sure the oxygen is on and count to 10. So 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, 5 Mississippi, 6 Mississippi, 7 Mississippi, 8 Mississippi, 9 Mississippi, 10 Mississippi. And so the bag is holding. It hasn't deflated at all. You still can't see the creases. So this machine is leak checked. And so just let it go a little bit. If there were a leak, you would start to see the bag deflate and see these creases come back. So now we'll just shut off the oxygen flow meter and make sure to reopen the pop-off valve. Alright, and now this machine is ready to use. So now we have our dog hooked up to anesthesia, so we're going to set up our monitoring equipment. So I have an appropriate size blood pressure cuff. And depending on the procedure, wherever it's more convenient, this can go on the front leg or a hind leg. You want to avoid, obviously, the leg that could have a catheter if you're using a catheter. Then we have our SpO2, so this measures the saturation of oxygen. And this can go, again, depending on the procedure, on the patient's tongue, or we can do it right above his penis. We have, one of the monitors we use here does have a ECG hooked right up to it. If we weren't using this one, we would want to do, if there's any question about a heart, we would want to do an ECG before surgery. So this patient is already in right lateral recumbency. We want to hook our leads up. And then apply some alcohol to the sensors. Right, and we have the ECG going. We have his heart rate. His SpO2 is 96. And we're going to start the blood pressure monitor. And this does have a temperature probe, but since we're going to be using the esophageal stethoscope, I have a thermometer here. We want to take his temperature ideally every 5 to 10 minutes during surgery and make sure it's not going too low. If it gets too low, we do have a bear hugger, a heating machine we can put on top of them to keep them warm if the surgery allows it. So now we have our esophageal stethoscope. And with this, we want to go on the patient's left side next to the tube and insert it until we can hear the heart. And we have a clock in surgery with a second hand so we can take a heart rate. And make sure what we get matches up with what our monitor is giving us. So that can stay in all through surgery. If we had a dog that bloated, we would use a gastric tube. So with this is a tube is too large for this dog, but you would want to measure your tube before you insert it. So you would want to go from the tip of the nose to the xiphoid, it's the end of the ribs, and then you can mark your tube with a piece of tape so you know you're not going too far. And we have a pump, so once we get the tube in, we can flush out the stomach before we do the tapping down. The tube we can do while the patient's awake. We would use a roll of tape, and that guides the tube. We use a roll of tape right in the patient's mouth and tape their mouth close around the roll of tape, and that'll give you a guide for inserting the gastric tube. It's sometimes easier though to do when the patient is under anesthesia. So this is our monitor. Again, it's showing the heart rate. Our SpO2 is 97. It's got his pulse. And so this machine, the ECG, will sometimes double count. So his pulse is really 74, which is, he did have dextrometer, so that's pretty accurate. And you can see he's got a nice normal ECG. And this dog is hooked up to a non-rebreather since he is so small, and he's connected to the isoflurane, and the rebreather is connected to our scavenging system. The non-rebreather is connected to the scavenging system. His blood pressure just read, and it's 75/52 with a map of 60. So that for a small dog, again with dextromethorphan, under isoflurane, that is normal. So for this dog's tube size, we went with a 6.5, and you can make sure it's not leaking. Once it's inflated, you want to make sure that it stays inflated. You also are able, if you listen, you're able to hear if air is being passed around the tube, and now that he's hooked up to the ISO, you should be able to smell gas if it was leaking. So you don't want to smell gas. If you smell gas, you know there's a leak or the tube is potentially too small. And with checking the size tube, I like to go by the space under their nose and kind of use this as a guide for what size tube you want to go for. But definitely, especially with dentals, you want the biggest tube that can comfortably fit in. You don't want to go too small. So we want to check this at least every 5 minutes. So another round has gone through. His pulse is still okay. His SpO2 is at 95. We can adjust the sensor and see if we can get a little higher reading. His pulse or his blood pressure is still normal, and you can still see he still has normal ECG with a P wave, a QRS complex, and then a T wave. With the non-rebreather system, so this is the end hook to the patient. Here is what would be the pop-off valve. So here it is open, and if you twist, you can close it, open it semi. Here it's closed, so you always want to make sure before you hook an actual patient up that you open it and it's not closed. And this is my preceptor, Kelly.
Hi, Kelly.
So we're going to put a catheter in the cephalic vein of this dog. I'm going to start by shaving. Now we have chlorhexidine scrub. And then rinse with alcohol. And one last time with the scrub. And rinse. And we have our catheter and our IV cap here.
Should I get closer to the leg?
Go ahead. So now I'm going to give a sub-Q injection to this kitty as her anesthesia pre-med. I'm just going to tense her skin and pull back first and then inject. So we're going to pre-med this dog for anesthesia. I have Torb dextromethor, and we're going to do an IM injection into his thigh. I'm just going to pull back and then inject. Good puppy. Okay. Good job, buddy. So now we're going to give this kitty her IV induction unit. So now we're going to get this dog ready to be neutered. We're going to try to put a catheter in his saphenous vein. I'm going to shave first. Poor old guy. Take the hair off. Now I have chlorhexidine scrub. And alcohol. We're going to put our cap on. And finish taping. Gotta keep my hand. Okay. So now we're just gonna flush it and make sure it's patent. Feels good. So we're using propofol to induce this dog. You just want to go slowly when we administer. He was induced with Torb, or pre-medded with Torb and Dextorm, so he shouldn't need all this propofol. We can check him for jaw tone. Pretty good. So we have our tubes, my laryngoscope. I'm just going to hold his tongue straight out between his canines and pull down his epiglottis. Feels good. We can squeeze his chest and just make sure we yep. Secured in place. Now we can hook him up to our machine. And we're using isoflurane as our anesthetic gas. And then we want to cuff his tube. And lube his eyes. We just have some artificial tear movement. Okay. So now we're going to pop this cap first thing. First thing we're going to do is check for a bladder and express it if necessary.
I ordered the Medicam for Riley over there. Okay. We can get some drugs now before we finish wrapping.
Did this dog get its Medicam, Jen?
I gave it.
Did you tell me that already?
I told you that when I did it. It'll pick up first and say to the person.
We have our clippers with a 40 blade.
No, it's all ready.
cleaning scrub and my alcohol.
You have to do the clippers, I can do his nails right down her, it. You're okay.
And rinse with alcohol. Rinse again.
I have Delana Franklin. She's actually in the pharmacy right now, and she has several dogs that we're going to be doing as an outback. So she should be done at the pharmacy here in a couple minutes talking to Julie, and then we have all the dogs here to admit, or I'm sorry, to do vaccine. We've got lepto, lime.
Okay, thank you.
You're welcome.
Do you know, have you dealt with Delana Franklin before? Do you know Delana Franklin?
I wanna say that I did, have something, that's an appointment or something.
Yeah, she usually usually do stuff right in the room with her, and she usually holds the dogs herself, kind of thing.
Oh,
I'm just giving you.
that's not written anywhere.
That's why I'm giving you like a heads up.
Thank you.
So, yeah.
Oh. He didn't like me playing, is this a girl or a boy? Whatever this dog is, doesn't like me playing between the toes. Done.
Thank you, Debbie.
You're welcome. And, I got a
Now
hand.
we're ready to move her.
Okay. Her.
Okay. So now we're gonna move her back in. I'm just gonna take my gloves and my coat off. Okay. What's up? Your patient. You're here. What's wrong with our patient? Yeah, get her over there. They're doing a video. Okay. Ready? Vaccinate her tight. cat already for her spay. And we're going to start by draping her. Now we'll set out the rest of the instruments for our spay. So now I'll put our scalpel blade on and then pass some instruments. And then our forceps. Okay, so we have our dog here prepped for her spay, and I'll be monitoring her anesthesia. So we have our anesthesia record sheet here to keep track of her parameters. So she is on 2% isoflurane. Have our monitor, her SpO2 is at 98. Her heart rate is 89. We'll start her blood pressure again. Her fluids are running. Check her capillary response time, refill time. That is less than 2 seconds. And her respiratory rate, I'll monitor for 15 seconds and then multiply by 4. At 12. And her blood pressure is 69. At 28, and then we have a 44. Okay, so if I were going to perform CPR on this patient, we would start. Okay, so if we had a patient that was under anesthesia and went into cardiac arrest and we needed to perform CPR, we would first verify for sure that there was no heartbeat, or if you had a patient come in that was flat out, you can feel for femoral pulses, actually feel for the chest, and then go from there. But if under anesthesia, we already have our animals hooked up to a tube and to the anesthesia machine. So ideally you'd have 2 people doing this and start with chest compressions. So this is a small breed dog or a cat, and you can just use one hand, and you want to go right behind the elbows where the chest would be on the heart, and do full compressions, but make sure that after you do a compression, you fully release. And then you can do to the beat of the song Staying Alive, or ideally about 120 compressions a minute. And as somebody is doing the compressions, it could be another person running the oxygen. So they're already hooked up. You would use the bypass valve and give a breath, and then let go. And do ideally 10 breaths a minute. And do another breath. And what you want to watch for is as you're doing a breath that your manometer goes to 20. You don't want to go over 20. So you may not need, especially in a small breed, you may not need a full squeeze of the bag. So you just want to squeeze until it gets to 20 and release. And then keep doing your chest compressions. So this would go on for roughly 5 minutes or so, and you can check an EKG and see where you get. So to start for a sterile scrubbing for surgery, first thing you're going to want to do is get your cap and mask and any other protective equipment, booties, anything like that you're going to need on. And then we're going to open our gown and our gloves and have that all ready to go. So we wrap these so that way they can be open from the outside and the inside can stay sterile. And then I have my gloves. And again, I'm going to open and not touch the paper. So now that our gown's open, we're ready to scrub. I've started by taking off my jewelry and making sure that I don't have any cuts or abrasions on my hands. Here we use preloaded povidone iodine scrubs sponges, so I'm going to get that open and ready to go. And then start by just doing an antibacterial hand wash. And then get our pick and clean under my nails. And then start our scrub with the sponge. So we're going to get it wet. We want to start in our non-dominant hand at our fingertips and do 10 strokes. And then start at the thumb and go to each finger, dividing into 4 quadrants and doing each quadrant for 10 strokes. spaces, same thing, 10 strokes. And then our hand in 4 quadrants. And then our arm. You want to overlap these as you go. And then do the same on the other hand. You can get your sponge wet if you need to. Rinse, always making sure that you start at the fingertips and keep your elbows down. Get your sterile towel. So once we're scrubbed, we're going to want to start by drying. We're going to take the corner of our sterile towel, being careful not to drip onto our sterile field with our gown, and start by drying our fingertips. And moving down our arm. And then repeat on the other hand. And then we can take our gown, first ensuring that our indicator strip has been turned black. careful here. Now we can do our closed gloving. We'll start with our left hand. And keeping our right hand inside the gown, use that to help pull the glove over. And move your left hand through as you pull the glove down. And the same on your right hand. Now you're ready to go into surgery. So now as she's closing the abdomen, and just blot so it's a little easier. Okay, so to moisten some tissue, we have some sterile gauze and sterile saline. So once in surgery, you want to make sure that you keep a sterile field. So you want your hands always above your wrists and your wrists always above your waist. Once you have your patient, you want to make sure that you don't touch any of the gown to the table until the drape is down, if your drape is sterile down. Otherwise, don't touch the table, keep your hands up. So in the operating room, surgery room, the duties of a sterile technician, you would be responsible for passing instruments, potentially putting the blade on the scalpel, threading a needle if need be, and then depending on the surgery, you may be required to keep tissues moist or blot up blood. And at any point, if sterility is broken, you need to take a step back. If your gown is compromised, you need the non-sterile technician that's in the room to help pull the gown off inside out. If it's just your gloves, they can get you, if you poke a hole through your gloves, they can get you a new glove and help you put your new glove over with an assisted gloving technique. If an instrument is dropped on the ground, ideally you would have a backup that's already autoclaved that the non-sterile technician could get. Otherwise, you want to do a flash sterilization if you needed that particular instrument for that particular surgery, but then there is going to be a lag time in between when you can use it. Alright, and now I'll be participating and monitoring in this catheter.
Yes, I'm going.
Alright, so now we're all done with surgery for the day, so we're going to clean up the surgery room. The first thing we want to do is take our pack out to be cleaned. And we always want to check it and make sure that there aren't any sharps. And here we do have a scalpel blade, so very carefully, if it's attached, you obviously want to take it off the scalpel. This one was not. We have a sharps container right in the surgery suite, so we're going to get rid of the sharps and make sure that there aren't any others, no more needles or anything like that. And then we'll wrap up our pad and take that out to be cleaned. And now we want to get rid of and put away anything else that's out. So we have our anesthesia machine. If there was any contamination, any fluids, anything like that got on the machine, we want to make sure we wipe that down before we put it away. And now we have our kennel care disinfectant that we'll use. So any surfaces that were in direct contact with the patient or in a 3 to 4 foot radius, we want to make sure we clean well every day. And more so the actual scrubbing and physical action of the cleaning is more important than the actual disinfectant. But we want to get all the areas that were in that 3 to 4 foot radius. And including our kick bucket. And then we'll let that sit for a few minutes. So we can go ahead and wipe down our table. We have our heating mat. We can wipe first and clean. going to do the whole table, like I said, anything within that 3 to 4 foot radius. Every day before surgery, you want to go around and wipe down any horizontal surfaces with a damp rag, and that'll eliminate a lot of the dust and any contamination that can be in the dust. And after all the surfaces are clean, we can do the floor. So we have a designated dry mop for our surgery suite. And we'll go around and do the whole room with this first. And then we have our wet mop with our disinfectant that again is designated only for surgery. And we'll do this after our dry mop and leave the floor wet and let that dry. So now we're going to clean the instruments in the pack that we've taken out of surgery. So we're going to put these all in the sink. And anything that is closed, hemostats that are closed and locked, you want to open. So you can do a good job cleaning. And then we have an instrument wetting agent that will spray on, and this helps to dissolve some of the blood. So this is our pre-soaking step. So we'll let those sit for just a minute, and then we'll go on to the cleaning. So now our instruments have been pre-soaking. Now we can go to the decontamination process. So we'll manually scrub and clean each one, making sure to get in all the hinges and everywhere. And then they'll go into our ultrasonic cleaner. So you just want to repeat this for all the instruments in the pack. Alright, finished the decontamination for all the instruments. They're all in our ultrasonic cleaner. So we'll set our timer and let that run. So now our instruments are done in the ultrasonic cleaner. So we'll take them out, give them a good rinse. Spread them out. Dry the excess water. And then we have our spray lube for our instruments that we'll spray, and then get ready to put them back in the pack. Okay, so our instruments are all ready to go. So we're just going to put them back into our pack. Here we have a metal tray that we use to keep everything contained. And then we want to add in a indicator strip. And so these start off with a white area, and then once they go through the autoclave, as long as they're sterile, it'll turn black. So we put that right in our pack. And then we also have gauze. And our sterile drape. So now we'll wrap, and we want to wrap in such a way with this outer or the inner drape that it can be opened by the non-sterile surgery tech, not touching any of the inside. And I also have a piece of steam indicator tape ready to go for the outside. did this in such a way that once it goes through, the non-sterile tech is able to carefully open it. And touch only the outside, so everything inside stays sterile. Once we have it wrapped with our inner drape, we have a fabric outer drape that we then put it in. Another piece of our steam tape. And then you just want to label the pack with what type of pack it is. So this is our SPAY or OVH pack, initials, and the date that it was done. So now we're gonna do fold our drape, or our. So aside from having the sharps container in our surgery suite, for any needles, scalpel blades, things like that, we would take any of the medical waste that goes into our kick bucket. So if we're doing a SPAY, the uterus, ovaries, any medical waste, we then have right outside the door our hazardous waste garbage can, and multiple times a day these get emptied and then burned in the cremator. So now we'll check on the packs. Our autoclave is finished running. So you can tell by our steam indicator tape with the black lines that this is sterilized. Our gown, same thing, the black lines. And our SPAY pack. So you can tell on the outside that this has been sterilized, but to make sure, after you would open this while you're in the surgery room, you also can check the indicator strip that we put inside. And there's our strip, and it's turned black. So this pack is sterilized. So when running the autoclave, we first want to make sure that we have enough distilled water, so it needs to be above the green line. And then you want to load it, lock the door, and choose our cycle. We always run packs and then hit start. So once the autoclave is started, the distilled water gets heated and turns to steam, and that steam forces any air that's in the autoclave out through the vent. And once there's no air and just steam left, it continues to heat up until it gets to the correct temperature, which is at least 250 degrees Fahrenheit. And that temperature and pressure of at least 15 pounds per square inch is kept through the entire cycle, which is at least 13 minutes, again, depending on what's being heated, unwrapped packs, pouches versus fully wrapped packs. And after the cycle is completed, the door is vented open. The handle remains locked, so you cannot open it, but the door vents itself a little bit to let that condensation evaporate, so that the condensation doesn't build up on the packs and ruin any instruments. Once the condensation is hopefully dried and the temperature has come to a safe temperature, the door unlocks itself and allows you to open it and remove your packs. So for maintenance of our autoclave, once a week we'll do a general weekly maintenance clean, and then monthly we'll do more involved monthly clean. So for our weekly clean, we first want to inspect everything and make sure all the gaskets and seals look okay. And then we'll drain out our water, refill it with fresh distilled water, and clean with SpectraClave the inside, let it sit for a little bit, and then wipe it out. Our monthly clean involves draining water and doing a clean cycle with speed clean and re-rinsing it out, running another cycle, and then ensuring everything is clean with the SpectraClave. So we, for the most part at our hospital, use absorbable sutures. All of our spay procedures, our neuters, everything like that are absorbable sutures. So I don't have a live patient, but we have a dummy here that has staples put in. But if I were going to take staples or sutures out of a patient, I would first see how long ago their surgery took place. We like to wait at least 10 days before we think about removing them, unless there's some sort of infection, the wound's breaking down, something like that. Otherwise, excuse me, we want to take a look at the incision, make sure it's nicely healed. If there's any scabbing, we'll gently try to clean some of the crusts away to better verify that incision site. As long as it's not red, as long as it's not clearly large open spots, we'll go ahead with the removal. So I have staples here. I'm going to take my staple remover and I want to go with the 2 prongs underneath the staple, push together and then lift up. Depending on how long it's been, sometimes these can be in there pretty tight, so definitely you may need 1 or 2 people to hold on to the patient to take them out. It's easier to see with staples than it is sutures most of the time, but you want to double check over your incision and make sure you've removed everything, especially with sutures. And once everything's out, you can then gently clean away anything else, crusts, any of the scabs, and go from there.